Hello, this is Dr. Nicholas Pejic of Atlas Psychiatry in New Orleans, Louisiana. Today, we are going to be talking with Dr. Andrew Anson of Atlas Psychiatry as well. It's a nice fall, crisp day here. And the topic today is psychedelics. Dr. Anson is not only a psychiatrist, but he's also a psychoanalyst, which I'm going to have you explain what that is in a little bit. And Dr. Anson has been studying vociferously, like a lot, about the topic of psychedelics, which is a hot topic in psychiatry, psychology, and medicine lately. So thanks for joining me for this talk. This is part of our deep dive series where we talk about one topic more in depth, of course. The topic of psychedelics, why don't you tell me, how does a psychoanalyst get interested in the science of psychedelics? And maybe you can tell us a little bit about what a psychoanalyst is to help put it into context.
Yeah, so everybody's heard of Freud, but Freud started the field of psychoanalysis, which is a more intensive kind of psychotherapy, usually involving exploring unconscious material, including dreams and other aspects of the mind. Freud did his psychoanalysis on the couch. Contemporary psychoanalysts today, like me, sometimes see people on the couch, sometimes see people face to face. But a lot of the original research on using psychedelics in the 50s and 60s was done by psychoanalysts, specifically psychoanalysts in Europe, who use low-dose psychedelics along with their psychoanalytic model to explore dream states, unconscious thought processes, and other kinds of dynamics that were sort of amplified using psychedelics in their treatment.
So they would do that back in you said the 50s and 60s? Okay. And then what happened that, like, did that research or that work go anywhere? And what happened after that?
Yeah, that research is still out there. A lot of it was used to inform the research that's been done more recently since the 90s, since the FDA started looking at psychedelics again for other kinds of psychiatric indications. There was a whole countercultural movement in the 60s and 70s about whether or not psychedelics would corrupt culture or cause people to be psychotic forever. And there was sort of a cultural panic around using these medications, and consequently LSD, psilocybin were outlawed in the 70s, MDMA was outlawed in the 80s, and they were all scheduled as controlled substances at the highest sort of level of restriction, Schedule 1, so they couldn't be prescribed and were illegal to use and couldn't even be researched until fairly recently.
So I'm just going to follow that story then. Why did they change the scheduling of them, or why are we allowed to research them now as opposed to like in the 1990s or something? Yeah,
so when the sort of last studies stopped in the 70s for psilocybin related kinds of things and the 80s for MDMA kinds of things, a lot of the research moved abroad to Switzerland. There have been nonprofit groups have continued to advocate for using these medications for a number of things, specifically for trauma-related kinds of diagnoses and trauma.
So you're saying that in the United States, they said we're not going to do this anymore because of, I guess, side effects or risks to the person, like namely psychosis or death from high dose of MDMA, and then
fears of addiction and fears of misuse, and that they would become drugs of abuse.
And then they kept on using these substances clinically in Switzerland, you're saying? And did this overlay, like the change in United States policy, was that part of the Reagan era drug policy, illicit drug policy too? Or is that part of it? Or
it's definitely part of it. Psilocybin had already been outlawed by then, but that was kind of the beginning of this sort of cultural backlash to experimenting culture.
Yeah.
And so by the 80s, not only were LSD and psilocybin outlawed, but MDMA and lots of things were sort of rescheduled in the war on drugs.
And can you talk a little bit about the umbrella term psychedelics and what sits within that umbrella term in terms of like what the medicines are actually, or drugs?
Yeah, the main ones that are usually referred to under the umbrella of psychedelic would be LSD, psilocybin, which is the active ingredient in magic mushrooms, peyote, the active ingredient of which is mescaline, and then MDMA, which is slightly different, hits slightly different neurotransmitters, is also usually included under that umbrella. Ketamine, which people are a little bit more familiar with, is not really considered a true psychedelic. It's more of a dissociative. So the main ones are LSD, psilocybin, mescaline, peyote, and MDMA.
Yeah, and that's something we're seeing now too, where folks speak of psychedelics all in one phrase or one breath. But like you just said, ketamine, which is a treatment for depression, which we do here at the clinic, works radically differently than these other ones. But they may make people have an experience that is different than the reality that we know.
Yeah. There's two I left out just because
not
being studied in this country as much, but ayahuasca, which people are familiar with, one of the psychoactive sort of components of that is DMT, which some people have heard of. And then ibogaine, which actually comes from an indigenous African psychedelic, which is also not legal here, but has been used in other countries to help cure addiction.
And those are usually used like is it usually in a ritual type of setting rather than like a clinical setting?
I mean, all of these traditionally would have been used in a ritual setting. Ayahuasca still is used in ritualized settings. Ibogaine, I don't know. Ibogaine is the sort of psychoactive derivative. I imagine that there are indigenous communities in Africa that still use. I'm blanking on what the original term iboga, I think, is something like what the original plant is called in Africa. So I'm sure that there are communities that still use that in some traditional way.
And let's talk about the neurotransmitters then. In a simplistic way, what's the difference between the LSD psilocybin group versus the MDMA group versus the ketamine group?
You probably know the answers to these questions at least as well as I do. Psilocybin and LSD tend to operate on serotonergic receptors. MDMA also works through serotonin, but it's sort of more of a stimulant than LSD and
when you say stimulant, you mean like more like the norepinephrine and dopamine. Okay.
And ketamine, you're the expert on.
Oh, ketamine is glutamate blocking receptors, and just for those listening out there, glutamate is one of the main neurotransmitters in our brain, the number one most plentiful. So if you block that one, it can really make you have an experience of dissociation. But we also think it kind of resets the brain in some respects, and it encourages neuroplasticity, which is kind of like your brain, the neurons in your brain growing and tightening up their synapses, and working better after the fact, after the experience. Anyways, but that's another deep dive, I guess. Okay.
Most of the psychedelics work through serotonin at some level. There's even I find this interesting, something like ayahuasca is actually two different, I think there's a leaf and a root. And one of the components actually acts as an MAOI inhibitor. So it actually sort of potentiates the effect of serotonin. And then the other component is more serotonergic. But the two together kind of increase the impact of serotonin.
So then you have all these different agents, most of which were made illegal, you're saying, in the 80s or 70s, 80s. And then what then changed where they started to think about using them again? I don't know if we have that answer quite yet. Why did they start researching them again, or How did they become?
There are a couple of big nonprofit research organizations that in other countries continue to do research specifically on psilocybin and MDMA. And once they could sort of demonstrate to the FDA that there were some positive results for psilocybin related to treatment-resistant depression, and for MDMA related to PTSD, post-traumatic stress disorder, that sort of reopened the FDA, and they did a lot of advocacy on a political level, and that reopened. And I think culturally, I think the suspicion of these drugs shifted in the last couple decades, but it got the FDA to restart doing its own research on psilocybin and MDMA since the early 2000s.
Yeah, and during that time too, medicinal marijuana became legal in that time frame, I guess, from the 2000 to 2020. We're here in 2023 right now, and then on top of that too, I think the treatment for depression and these things, like we run out of options because you can't do brain surgery to fix these things. We have transcranial magnetic stimulation, which is limited, and they're doing a lot more research to find more use for that. But yeah, so we basically need better treatments because all these folks are suffering out there and aren't getting well.
Specifically for PTSD, that there hasn't been like a new treatment approved or recommended in the last 20 years, I think also is part of the backdrop to, even if MDMA helps a little bit, would that be a positive contribution to a diagnosis we don't have any other new treatments for?
Right. So then tell me, how do you then get interested, because you're prescribing medication as a psychiatrist, but you're unique in that to have that added training as a psychoanalyst takes a lot more work and time, of course. And for those listening, you want to tell them like how frequently you would see a patient who's undergoing psychoanalysis and for how long you might see them for?
Yeah, a typical psychoanalysis would be 3 times a week sessions or more for a year minimum. I have patients I've seen for 4 or 5 years. There's some flexibility in that. And so there are people that come twice weekly for analysis. And obviously it's a huge time commitment for anybody who decides to undergo that kind of an exploration of something. But yeah, 45 to 50-minute sessions 2 to 3 times a week for at least 6 months to a year.
And what kind of problems are these folks coming to you with? And in the business, we would call this, the chief complaint.
All kinds of things, but a lot of past traumas, relationship issues. I not infrequently see people that end up self-medicating some other kinds of symptoms or diagnoses with other substances, cannabis, other kinds of sexual and gender explorations, other kinds of depressive symptoms, obsessive compulsive disorder.
And the theory there is that they have some kind of conflict psychologically that they need to work through, and they may not know the conflict, or they're just not aware of it yet, or is that just part of the story?
The idea would be that perhaps there are other kinds of unconscious dynamics or experiences, that perpetuate some kind of a symptom or some kind of a repeat lived experience, that being able to become curious about the unconscious mind and patterns in someone's life, specifically how they relate, and in a therapy that's meeting with this frequency, it becomes a very intimate treatment setting to really find out how somebody relates to me and how they relate to other people in their lives, and to add all that information to what keeps somebody from having a new experience, how that affects what has changed or hasn't changed, or gotten someone to where they want to go in their life.
So you're doing that, as you're doing that type of work, you then get interested in psychedelics. And how did that happen? I mean, you referenced it earlier, but how did that happen, practically speaking, for you?
I mean, even when I did my psychoanalytic training, I was always curious about these older European psychoanalysts who did work with psychedelics. The term that they use is psychoanalytic psychotherapy. Okay. So it's actually smaller doses than the Americans who were studying psychedelics at the same time were using. So we refer to the American studies as using indigenous doses that were sort of mystical, religious, out-of-body, higher dose experiences, where the Europeans were using smaller doses that sort of opened up people's inhibitions and allowed people's conflicts and their unconscious associations to come out more easily.
Okay.
And I always thought that model was fascinating, but I followed the research at the FDA, and as new sort of studies surfaced and results, found the idea of using these kinds of components and some kind of a therapeutic practice really compelling. Two of the sort of primary studies the FDA is considering are using psilocybin and MDMA respectively in psychotherapy-assisted protocols.
And the reason for that is that you're kind of loosening up someone's psychology, whereas usually we're defended a bit, right? Defended meaning like what's a good way of explaining that?
Resistance is the...
resistance to talking about, to talking about these conflicts.
But yeah, we're all defended from our unconscious stuff that we keep under wraps.
We keep it under wraps.
Today.
Yeah. And so if you're going to loosen that up, you need somebody with kind of kid gloves to go in there and to really hold them in a way, right?
Yeah, and this is where I think actually the research in the 60s and 70s was instrumental. So if you've heard of the name, a lot of people have heard of the name Timothy Leary. He was one of the pioneers of doing psychedelic research in this country until it was shut down. He moved abroad to Switzerland and continued some of that even after the 70s. He coined the term the set and the setting and found that whether someone had an adverse reaction or had a therapeutic reaction to a session with a psychedelic had a lot to do with both the set, which is the mindset, which sort of it can be prepared with a therapist or a guide going into a psychedelic session, and the setting, meaning is it while you're rolling in a Mardi Gras crew, or is it in a safe therapeutic office or ritualized experience, and that had a big impact on how safe people felt when they were exploring these kinds of things, and whether or not it was ultimately a positive experience or an adverse reaction.
Well, as we're talking to you, I'm noticing your picture to your right, and how that might engage somebody, or they may they're having this experience. You have things in there that they're going to react to or respond to, right?
Yeah, there's actually a lot of interesting literature around what should be in the setting, and I've been fascinated by people's thoughts on this for a while, but having bright colors, having abstract art are things that are commonly mentioned. Having it feel more like a living room than a sterile clinical setting often comes up. Having nature or greenery, and you can't see from this view, but we do have a lovely landscaped backyard to all of our Atlas offices.
That's pretty neat how it all comes together and to create that experience with folks. So if you were to do this type of therapy, well, and I guess we'll get to whether or not this will become mainstream one day. Would you be face to face with the person? Would they be laying down and you to the side, or how would you envision that happening?
There's a big debate in the field even right now, and as I'm doing this training, there are people of different sort of orientations and different views. There is the way a lot of the research is conducted is with some like introductory sessions, and then 1 to 3 sort of administrative sessions, which are usually done laying down like on a bed or horizontally on a couch with eye shades, headphones, and with some kind of a predetermined soundtrack playing, with 2 therapists in the room. It goes for 8 hours, and then there would be a handful of integration sessions with a therapist after that experience.
Afterwards, like on other days, of course.
On other days. But there are people within the field who find the psychoanalytic model a more compelling model. So doing this work with someone you have more of a therapy relationship with over a longer period of time at lower doses. And those models tend to be more open to the idea of people either sitting up, or actually on a lower dose, you could communicate more than you can in the indigenous doses of these medications, so that you would actually be sort of telling a therapist what you're experiencing, or you could. So there's some different models out there, and I think what's interesting about the time that we're in now is we can sort of have a conversation about what we think the best practices for these kinds of things would be. But I do think that's an important conversation to have before they're legalized and being used.
And do you foresee if this ever gained FDA approval, can patients take it alongside other psychotropics? Is there much worry about serotonin syndrome or things like that quite yet?
There was, and a lot of the research protocols have modified so that they don't rule out people who are on an SSRI. An SSRI contraindication, being on an MAOI inhibitor, which most people might not have heard of, but it's a stronger antidepressant that's irreversible, would still be a contraindication. But
it would be a contraindication.
Yeah.
So, and just for folks listening, MAOI would be like Parnate or Nardil, and then SSRI would be like what?
Lexapro and Prozac.
Lexapro, yeah, Prozac. Okay. And so you're saying if there's a possibility that folks might have to taper off those to endure.
So the general thinking, the latest thinking is people wouldn't come off of their SSRIs to be on a psychedelic. Whether that people would need a slightly higher dose with some antidepressants is one question that's, I think, unanswered. And yes.
And right now, when you are doing psychoanalysis, either 2 to 3 times a week, are you face-to-face with the patient, or are you behind them and they're laying down, or is it mixed sometimes?
It depends. I've done both. Most people, at least in the beginning, tend to prefer to be face-to-face. And I think there's advantages for some people in being able to see my reactions and be face-to-face. So I think it just depends on the person.
And if you're assisting the psychedelic experience by being in the room, and it's an 8-hour experience, you mentioned using headphones or earplugs, music, and like what, night mask or something?
Yeah.
So what's the purpose of the therapist in the room then if they can't see or hear you?
And the way the study protocols are designed now, primarily for safety. It's not unusual for these medications to stir up either some anxiety, panic, to hallucinate in such a way where somebody isn't quite sure where they are, or wants to get up and move around. And part of the role of having someone in the room is to make sure someone stays safe, to reassure someone.
And is there any point during the 8-hour experience that you foresee talking to the patient about their content or what they're experiencing, or helping them work through it? I can imagine they would feel much safer having a therapist in the room that they've talked to, if they have a comfort level, depending on the transference and all that stuff.
That's a great question. Most people would agree, even if the patient isn't going to be talking at all, it's still as vitally important that they know who's in the room with them and that they trust them. And even if they're not talking or interacting with that person, they still are aware that person
because you're part of the set, as you mentioned then.
Yeah, that'll be part of the setting, and that by itself might change the experience to know I'm with a trusted provider who I already have met and talked to, and I know is going to keep me safe, and I've already established trust with them. It's more common for patients to talk at all with MDMA than with psilocybin or LSD.
I mean, they're more chatty with MDMA and less with the other ones.
Yeah. And
also, I can imagine if you're viewing and hearing their experience, if the patient's talking about what they're seeing or enduring, and you have that firsthand knowledge, you can integrate that into their post-therapy sessions, right?
Yeah. Even not having been able to do this work with people since it's not legalized yet, I've had psychoanalytic patients who have gone and done their own psychedelic experience, which I can't recommend or advocate for, but have come back to psychoanalysis to talk about what came up in their trip or their hallucination. And it was always things that either came up in other dream material or brought up other kinds of dynamics with family or fears or things we talked about in therapy for years. So I don't think there's any accidental trip. I think it's always
And
someone.
and have you found that new information helpful to move them along in terms of their growth and their understanding of how they work?
Sometimes it's really helpful. Sometimes people's reaction is, I can't believe I waited this long to have this kind of an experience, or we came to a sense of some of these unconscious things over years of psychoanalysis, and I had all these experiences in one 8-hour trip. I wish I had done this before. And I think that is why this would be sort of a missed opportunity not to have this to be a part of some kinds of explorations in therapy.
Let's talk about maybe the experience of tripping in and of itself. I know from patients and probably friends who had used psychedelics tell me that they may have felt changed after it, perhaps more empathic, or they're almost more in tune with, I want to say the universe, but it's as if they can understand the frequency of living things in our world and how everything is somewhat quote unquote connected. Can you speak about that, or is that stuff that you've heard, or is it different than that?
No, I think that fits with people who have their own experience of these things, what they might say. I think a lot of indigenous communities thought of psychedelics as being either gifts from the gods or being a way to sort of commune with the divine.
Mm-hmm.
And I think even in sort of countercultural groups, being able to have a mystical experience or a profound experience is part of how local communities, even here, have thought about these things.
Mm-hmm.
There is some evidence that these things tend to stimulate and activate the parts of the brain that are related to meaning making and trauma and emotional experience and motivation. So I think it would be not surprising on a biological level that those are the kinds of things that people describe, that we're all connected, that there is a shared consciousness, that we're a small part of something much bigger. That there is.
And when you say chant consciousness, what do you mean by that? Like it's an actual chant and they're hearing it, or they're feeling it or something?
Sorry, that we're all part of a shared consciousness.
Oh, shared. I thought you said chant consciousness.
The idea of like the collective unconscious, that there is no sort of limits to the unconscious mind when you sort of tap into that in the context of a psychedelic trip. Or that the unconscious is somehow much more real than our conscious waking minds. For a great description of this, the author Aldous Huxley, author of Brave New World, self-experimented with psychedelics and wrote a beautiful essay about his own psychedelic trip. And he had a way with words and talks exactly about these kinds of things.
And is that available where we could put it in a link below?
Yeah, let's add a link below afterwards. I'm blanking on the name of the essay, but
okay.
I think it's, I don't want to get it wrong, but we'll put a link to it.
It's super neat. So what does that do for folks then afterwards? Like say someone had psychiatric symptoms of either depression, anxiety, post-traumatic stress disorder, whatever it may be, they have experience like that. The collective unconsciousness part and having tapped into that during their trip, what does that do for people afterwards from what you know now from your studies?
A lot of people would describe having been able, in the context of a profound trip, to face their fears and to be able to sort of go to the painful place, or to look at the trauma, or to consider aspects of death that otherwise would have been terrifying, but can be finally sort of like faced in a way that's profoundly healing. People that are otherwise depressed or isolated sometimes will describe feeling infinitely connected or joy on a different level in the state of one of these trips, and then process afterwards, not knowing that was inside themselves and what it would mean to be able to hold on to some aspect of that experience.
You remind me of in your comments about a patient that had treatment-resistant depression that underwent transcranial magnetic stimulation, and they couldn't get the person well. And I think they had one treatment in Europe with the psychedelic, and they responded, their mood improved, and then they were better for many months afterwards, as opposed to patients who have to take something like Lexapro daily for maintenance medication. So I got lots of kind of questions I could ask about this, but is it your understanding that there will be a more prolonged response with psychedelics after patients would undergo this type of experience? Number one. And the second kind of question would be, just so I get it out there, is do you think that there's an issue with spirituality in our culture or world where we don't, because back in the Middle Ages, there's religion kind of imbued a lot of things, which are good and for bad, right? Whereas now, I think it's like a snow globe. The world's been shaken up. We have so much information. We have people traveling away from their family of origin. You can live in multiple different places in the United States and the globe and still connect, but are we really connecting?
Mm-hmm.
And it's my impression that I don't know, people just maybe aren't as spiritual. And I don't know if religion, and I don't mean to say that religion and spirituality are exactly one for one. They're kind of different sides of the same coin, maybe.
Mm-hmm.
So sorry. I guess there's the spiritual question, and whether or not these things help people be more spiritual, it would be the question.
Mm-hmm. To your first question, I don't think we know the answer. So,
okay.
I think we have some evidence and some of these studies that had like 6-month follow-ups that there was still some benefits. But I don't think we know definitively whether or not there's lasting effects. I think there's also an assumption that someone even who's going to do sort of like a 5-session psychedelic protocol, like is in these research protocols, would still continue ongoing therapeutic work with someone, even if it's not necessarily a person who's administering the psychedelics. So I think all that probably has an effect on what the long-term outcomes are, and how much of that is related to the psychedelic and how much of that is related to the therapeutic work is probably up for debate. In the psychoanalytic model, where someone would have an ongoing psychoanalytic relationship with a psychoanalyst, the model then was to do like a psychedelic low-dose session like once a month on an ongoing basis, almost like more of a maintenance model, which I think is kind of interesting, which is not exactly how it's being studied by the FDA right now, but I imagine at some point that will be explored or repeated.
They'll have to answer the question of how do you carry on beyond the first one. Yeah.
And to your second question, I'm sure you're onto something. I'm not an expert on spirituality as a psychoanalyst. I certainly see people who come in with different abilities and setbacks to their meaning-making capacity, and I definitely trauma affects that. I think depression, to the extent to which it limits people's ability to have a new experience and make meaning and be surprised, affects that. And so I definitely think that there would be a natural overlap between something that could help with meaning making and surprise and discovering new kinds of connections that's akin to a spiritual practice. And I think it's why spiritual communities who've continued to use psychedelics in some kind of a ritualized way are big advocates for there being some way to legally have access to these kinds of substances. And the biggest proponents to psychedelics being researched and descheduled come from indigenous or religious communities who think that there's an obvious connection between the two. I certainly think in the post-COVID era, there has been such an assault on our ability to sort of be connected in lots of ways that even before the pandemic we took for granted, that I think that there are a lot of people out there that come into our offices because of their inability to be connected, and that manifests as a psychiatric symptom. But so I certainly think that there's a connection between someone's spiritual or meaning-making part of their life, or the absence thereof, and psychiatric symptoms that bring people through our door.
And you reference, well, the indigenous kind of research or use indigenous populations using psychedelics as a tool, right? And part of the ritual. Is there any conflict or issue between scientists and the indigenous community in using a tool that's been used for a long time and kind of co-opting it for the treatment of depression and PTSD?
Yeah, there's also a big conversation within the field right now about that very question. What does it mean for us to take some wisdom that's thousands of years old, medicalize it, FDA approve it for Western scientific indications, and have a pharmaceutical company make lots of money off of it? There are lots of conversations about who benefits from these modalities. How do you include indigenous communities and cultural wisdom on these kinds of practices, and the conversations that need to be had about how these kinds of medications are rolled out in a community or a culture. And the training I'm doing, almost half of the sort of presenters or educators have some kind of indigenous or cultural background to speak to other sort of ways these substances have been used and their histories and origins. And I experienced my first drum circle and doing a psychedelic-assisted psychotherapy workshop a couple weekends ago in San Francisco.
Well, and what was that like for you?
It was kind of wild. Without there being any psychedelics involved, just to clarify.
Yeah.
I was convinced by the end of even like a 20-minute sort of meditative drum circle that I was in sort of a different mental space, and my brain was associating based on the frequency of the drumming some very interesting things that then we explored as like a group afterwards. And so whether it's other kind of meditative practice, holotropic breathing to be able to get the brain in a different kind of state using meditative breathing, have approximated psychedelic-like experiences for years when psychedelics haven't been possible.
Well, one thing comes to mind as you're describing that is, does this need to be communal or not? And you've said from the research from the psychoanalysts that they were testing this out in a room, and that Timothy O'Leary is saying, like, the room matters. The person in the room with the patient or client matters. And then there's a whole privacy around treatment, and group therapy versus individual therapy. Small communities. Do you want people to know your business in a small community? And we always talk about how New Orleans, you run into people all the time, and everyone's like 1 degree of separation or half degree of separation here. It seems like, say hi to your mom and them. So I'm wondering if this is just an evolution of these tools to be adapted here. And would there be another way of doing that if someone wanted privacy, and what else would they do? Do they have to be in a drum circle with another group, or not? And does that come into the fore at all with indigenous populations that do this type of work, if I could call it that, or provide this type of service to their communities? Is there any sensitivity around patients who suffer from these terrible disorders, like our patients we see here with depression and PTSD and anxiety, whose lives are hollow because they can't function? Does it really, does it justify, using the wisdom, in this way?
Yeah, it's a great question. I think it's hard to directly compare traditions in indigenous communities with Western, very individualized American or capitalistic culture.
Yeah.
There are some research studies that are looking at in like the integration session, could that be done in a group? And is there a benefit to there being a group, especially if part of what comes out of a psychedelic experience is feeling connected? And so I do think there are more studies on, should it be individualized? Is there a benefit to being able to have a group integration experience? I remember someone asking an ayahuasca, she's actually a German physician who's also half Mexican and works with indigenous ayahuasca communities in South America. If there are some diagnoses, schizophrenia, for example, where someone would maybe not be suitable to have a psychedelic experience or could have worsening of psychotic symptoms,
Right.
How would those indigenous communities have a way of thinking about not having someone participate in the ritual? What is their screening criteria? And she said, if you're in a small Amazonian village where the medicine man has known everybody in the village their entire lives, even if they don't know it is schizophrenia, they know everyone so intimately that they would know what dosage or what kind of substance or not people would in their community would respond to or not respond to before they even come to a ritual, because
meaning they might find someone too fragile to undergo it because they know that person, or they're not stable enough to endure it or something.
Yeah, but they would know their community so intimately that even our way of thinking about community is so different than maybe a small Amazonian tribe that's lived together their entire lives.
Well, it's interesting because we'll have patients do group therapy, and they'll come back and want to talk all about the other people in the group and how they were affected by the other members. And I can't imagine, I can't imagine folks getting together and having the experience together. But do you just meet them on day one and you sit in a chair and you're just doing it? Or do you have 3 or 4 sessions, get to know people, and then their stuff, meaning like their life stories, their issues? I worry about patients being re-traumatized by sometimes hearing other patients' stories, which, so very interesting.
I think that is why there's a lot of thought around what would the training be for someone who's thinking of doing this kind of work individually or in groups? Would you need someone who has some sense of how you keep people safe if somebody's going to share their trauma in a group, or how to navigate group or individual therapy dynamics? Because I think this does stir up a lot of stuff for people.
And then the one thing, Dr. Anson, I was thinking to ask you is, what about bad trips? Like, that's one thing we don't talk about. We think of this treatment as, hey, everyone's going to get better. But we all have had that friend who said, hey, man, I had a bad trip and I was a sophomore in college and X, Y, and Z happened to me. So is that a possibility, or is that written about, where folks have an adverse reaction and say, hey, that was not helpful for me, I went off that ride?
I think it's an interesting question. I don't know what the answer to it is. I think there are some people who would say, if the setting is created in a thoughtful enough way, that by itself protects against what a lot of us mean by a bad trip. But there's also non-judgmental approach that is sort of a prerequisite for all guides or therapists thinking of doing this kind of work, where lots of stuff might come up and they encourage you to not judge it. But even if it's a really painful, or even if it's going to go to a traumatic place, that might still be a really important and healing thing to happen, where in the wrong context that would have just been a bad trip, but in the context of a therapeutic setting could be a really painful experience that someone survived in a safe and therapeutic setting that ended up.
And in good faith, we're all trying to help each other out here and promoting wellness and healing. And there would be an informed consent prior, letting folks know that 2% of people, or whatever it might be, have an adverse reaction or elevated heart rate or whatever it might be.
So there are usually protocols for if somebody becomes fully psychotic or has a very negative reaction, how you would keep that person safe. But even for someone that becomes very afraid or disoriented or has a panic attack, I think that's not considered a bad trip or an adverse reaction if it's part of what needs to come up and be explored, and can be contained in a safe enough way that somebody's able to get to the other side of it and make sense of it.
Yeah, I had a friend one time tell me that he had used some psychedelics and thought for like several hours that he was an orange, and he couldn't get out of like the orange rind. And like, sure, there's some information there, but he said he just didn't feel right for months after the fact. And but he had used psychedelics prior to that time with good experiences. So I was always curious to know, could one use too much or go too far, too frequent of use? And I guess this is what you are studying now, and what the research, all the research has pointed to, right?
Mm-hmm. I do know in like some of the writings of these European psychoanalysts from the 60s, they would describe, so they first off will go very slowly in the dosing, and would like make notes on if they thought somebody responded to a lower dose and maybe couldn't tolerate a higher dose, and eventually would get to a point repeating this with someone where they did know what kind of dose was too much and what dose was optimal.
Which is why this is best done with somebody who knows what they're doing, like a clinician, or I guess in different cultures, like a medicine man who understands it. So what about the future of this from this point forward? Like, I keep on hearing about psychedelics. My patients ask me about it. We do prescribe ketamine, which is already FDA approved, which is different than a typical psychedelics that you're talking about. What is the holdup now of this becoming approved? Are they, and for approval, can you talk about the FDA approval process a little bit?
Yeah, so there's 2 studies at the FDA right now that are in phase 3 trials.
Okay.
An MDMA study and a psilocybin study. The MDMA study is probably a little bit ahead of the psilocybin study, but both have some initial positive findings, and are thought that there will be positive enough results after those findings are analyzed, critiqued, and studied to get an indication in the case of MDMA for PTSD, in the case of psilocybin for treatment-resistant depression.
Okay.
And when that happens, that they will likely be descheduled by the FDA, meaning they will no longer be substance 1 controlled substances or Schedule 1 controlled substances. And if they have an indication on the federal level, then opens up the possibility that they could be prescribed on the state level by local practitioners, with whatever kinds of recommendation the FDA makes for how they should be used and what kind of training or certification you should have to be able to administer these medications.
Okay.
It's not guaranteed that that's going to happen. For a while, it was looking like by the end of 2023, those indications would be forthcoming. Now it's looks like it's at least pushed back until 2024. So there's a lot of hope, and because of how long it's taken to sort of even start researching these things again, people who have been advocating for these substances to be researched and have a therapeutic use since the 70s and 80s are sort of hopeful for the first time that there will be a way to incorporate this into psychiatric and therapeutic practice. Again, it's not guaranteed.
Sure. And
and
what's your most
out of a study at this moment in time,
say that last part?
and not legalized outside of a study to use in this way at this moment in time.
What's your most favorite part about studying this this topic?
I've always been interested in the unconscious mind, whether it's dreams or when I worked on psychiatric locked units, the kinds of hallucinations patients would have, which are always sort of unique and specific to the individual in some way that oftentimes didn't make a lot of sense, but if you had enough time to get to know the person, you might be able to analyze sort of what they're coming from or what they're about, or what some of their conflicts or fantasies or fears were about. And so to finally have kind of a pharmacologic basis to think about these things and a way maybe to study them in a more controlled setting and to use them in therapeutic work, I think has a lot of potential, possibly. So I find it fascinating that we, in my lifetime, might be able to have another way to understand the mind and how our unconscious mind works and the role it plays in healing, which I've always suspected was important as a psychoanalyst.
Yeah, it's one of the things in growing up in this era. If you did not try psychedelics and you hear about them, the experiences folks have from them are so profound sometimes. You wonder, could it be rite of passage even, or preventative medicine of some sort? Like you said, some of these patients working in therapy, and then they will have done the experience, and they're like, well, wow, this all kind of came together for me now. I'm just curious about that. Beyond that, do you find that your patients are interested in this topic, and do they ask you about it?
Just in the last year, I feel like patients have started to bring it up a little bit more. I think knowing that I'm interested in this field prompts some new patients to bring it up. And I usually tell them my curiosities about it, but there's no way to use it in a therapeutic modality at this moment in time, but that could change in the next few years. So I do think it's important for psychiatry and psychoanalysis to have something to say about these things, which is why, as a psychiatric psychoanalyst, I felt like it was important for me to study this field, do the certification to be trained, and ultimately I'm imagining I will have opportunities to teach about it if it is legalized. And I think every psychiatric resident and every psychoanalytic trainee should know something about this.
And what ages do you think that this treatment would be allowed in if it were to become FDA approved? And I'm not saying this is medical advice or holding it to it, but what do you surmise?
I don't know of anybody that's researched using it in children, so I think it'll not be used in kids. But I think in adult populations, with maybe some qualifications in terms of like the increased heart rate in older populations, and then with other specific contraindications for other psychiatric diagnoses that would be more predisposed to having psychotic symptoms. But I think all of the different populations that might have some benefit, I think, is still being explored.
And is the idea that these might be safer even in older adults, since they do not cause like respiratory suppression and things like that? From what I know now, again, this is not medical advice for the community listening to this, but just asking.
Yeah, I think they're generally thought of as fairly safe, and they have been studied. Psilocybin in particular has been used in cancer populations, which tends to be older patients, especially people with terminal cancer diagnoses, and explore the trauma of a terminal diagnosis and end-of-life issues. Already, I think that there is some research in using these substances in different kinds of populations, including people with other medical or age-related risk factors, with by and large very few adverse outcomes.
And that's interesting too, because in the hospice, if it were at the hospice phase of treatment, having a meaningful experience and preparing somebody for end of life might be a very important tool.
And people will talk about being able to go through this kind of experience and not having the same terror about death.
Yeah,
which is a pretty amazing thing to think about.
Well, this is exciting to know that you'll be able to help folks and hopefully provide this in New Orleans one day. And I really appreciate you coming on and talking about it. And then hopefully you can keep us up to date as the science progresses, and maybe there's an FDA approval with one of them one day.
Yeah, maybe we can do a follow-up deep dive at the point at which it's approved, and I can talk about actual experiences having used this modality with my own patients.
Absolutely. Well, Thanks again.
Thanks, Dr. Pejic.
Okay, see you soon. Bye-bye.